really excited to hear from Heather and Katherine today about some challenges they had and how they look to overcome those and maybe what they do different in the future. My name's Linnea Austin-Johnston, and I'm with CTO. And for those of you who do not know as much about Research Ready Mentor Spotlight, this is a CTO program aimed at sharing best practices and expertise from our community mentors on specific topic areas. And we have a new topic each month, so keep checking back to see what next month's is and each month going forward. We have live session today, which you are more than welcome to ask questions either in the chat or by unmuting. I think we'll spend 10 minutes at the end answering questions. So think of your questions and feel free to add those to the chat as we go along. This is also being taped, as you may have just heard, so it will be available on our YouTube channel and ready for viewing by anybody. So if you found it very helpful and would like to look back at it later or want to suggest it to a colleague in the future, just check out our CTO YouTube channel for these and past mentor spotlights as well. Finally, we do offer a certificate of attendance for those of you who are live today. We just will ask you to complete the survey at the end of this session. So once we complete the Zoom session, then there will be one more window that pops up, and just click that to complete a very short survey. And that will allow you to identify yourself so we can send you out a certificate of attendance to support your continuing education credits. All right, so that's it for housekeeping. I'm very happy to introduce both Katherine McPherson and Heather Baresh today. Katherine is an RN who has been involved in clinical research for the past 22 years. She is currently the lead of the clinical research coordinator at Southlake Regional Health Center, where she's responsible for the oversight of oncology, cardiac, and COVID-19 trials. She's also a huge contributor to our CTO Act subgroup on site self-governance. So we really appreciate her and look forward to what she has to share with us today as well. Heather Baresh has nearly 20 years of experience coordinating and managing many multi-site national and international clinical trials at PHRI. Her experience includes the management of investigator-initiated and industry-sponsored trials in the areas of cardiology, stroke prevention, and now more recently in COVID-19, which you'll hear about today. So with that, I will pass this over to Heather and Katherine. Welcome.
Thank you so much, Linnea, for that excellent introduction. Katherine and I are going to tag team this talk a little bit today. We were both collaborators on the ACT COVID-19 trial, but we have somewhat different perspectives. I'm on the central coordination team at PHRI, Population Health Research Institute, and we're the sponsor of the study. And Katherine was a coordinator at Southlake, which was one of our clinical sites involved in the trial. So we'll be able to share a little bit about our experience in this trial and specifically about remote consent and from our two different perspectives. And hopefully if you are planning some trials or going to be participating in trials in the future that have some of these elements, we'll be able to share some insights that might be helpful for you. All right, so in terms of what we aim to cover on this session, I'm going to start off first and give you a little bit of background about the trial itself, the overall design and the context, really just to set the stage for our discussion. I'll talk a little bit about the decentralized aspects of the trial and the global perspective as well. And then I'm going to pass the baton to Katherine. She's going to talk about her experience specifically with remote consent in the inpatient setting and also with a unique referral model that we implemented in the outpatient setting in Ontario. Then she's going to pass it back to me. I'll talk a little bit about our hub recruitment outpatient center and our success rates and what are some of the lessons that we learned. And then I'm going to pass it back to Katherine and she'll lead some discussion about where we go from here. All right, so let's start us off. The ACT COVID-19 study was an investigator-initiated trial sponsored by PHRI It was had some funding support from a CIHR grant and as well from Baresh Pharmaceuticals, who also provided some of the study medication. It's really two trials in one because we did a parallel inpatient trial and an outpatient trial, which gives us a great opportunity to look at the full spectrum of disease, as well as to assess the two populations separately and combined. It was a phase 3 open RCT. It also had a factorial adaptive design, which was something we really started to see more of in the COVID-19 era. Many of these large platform trials.
Yeah. I think our challenge is going to be having Joe punt things back to them.
Oh, can I get some? I'm hearing some background talking. Thanks. Okay. So with the factorial adaptive design, this was a common setting in the COVID-19 setting where we had to pivot to different treatments in the design itself over time. And our objective, of course, we all know vaccination is the best strategy for dealing with COVID-19 by preventing it in the first place. But for those that do contract the illness, our goal is to prevent progression to worse outcomes, hospitalization, ventilation, or death. Okay, so how big was this beast of a study? We started really quickly in the early phases of the pandemic. I think the planning of the study started around March 15th of 2020, and our first patient was enrolled April 19th, 2020. So really quickly, we did have to make a pivot, as I mentioned about the adaptive design. We modified the treatments we were testing, and we restarted it in August of 2020, and that's the iteration we have been able to bring to completion. In total, we have involved 15 countries and 136 hospital or clinic sites around the world. We have, I'm very delighted to say, enrolled 6,671 participants. And we just completed recruitment last Thursday. It's been a really busy week and a week of celebration. So we're really delighted to have reached our targets and our milestones. And we're now wrapping up and collecting data for our primary endpoint, which is at 45 days of follow-up. And we're anticipating to be able to analyze that primary outcome as of April of 2022. We also have a 180-day extended follow-up as well, which will give us some important information. And really, this is the third largest global COVID trial after the WHO initiative and the UK Oxford Recovery Trial Initiative. This is the third largest in the world, which is really exciting because, you know, it was born and bred right here in Ontario. And so that's exciting to be playing on that stage. I'm not going to go into the details of the inclusion and exclusion criteria because I don't think it's really relevant to the study, although it's here if you're interested, except to say, of course, we had two parallel trials, outpatient and inpatient. All patients that were enrolled in the trial had symptomatic COVID-19, laboratory confirmed, and there was a time element to it. They needed to be diagnosed within a period of time, within 7 days for outpatients, and within 72 hours of admission for inpatients. So there were tight timelines, and that certainly impacted some of the logistics around enrolling participants. For the most part, the inclusion criteria are the same, except that the outpatient trial, we needed some additional risk criteria just to enrich that population and make it more achievable to find a signal without having to enroll many tens of thousands of patients. And just very briefly, because again, the treatments we used are not so relevant to this discussion, but if you're interested, we did a 2x2 factorial. This is the final iteration of the treatment strategies that we were able to bring to completion. We used an anti-inflammatory strategy, which was colchicine versus usual care, and we used an antithrombotic strategy, which was slightly different in the inpatient and outpatient setting. For the inpatient, it was aspirin, and for the outpatient, it was aspirin. And for the inpatient, it was rivaroxaban plus aspirin. All right, and here is where we sit with our recruitment numbers. I'm not going to go into detail, but you can see very quickly that we really span the globe in our involvement in this trial. We're going to focus our discussion on the Canadian experience. We enrolled 354 outpatients in Canada and 92 inpatients. There were 9 sites in each, and for the most part, these sites in Canada were not overlapping. There were a couple of exceptions. Southlake, for example, where Katherine was one that did both. And perhaps the only other thing I might want to point out about this slide is that, we're going to talk about logistics and challenges that we experienced in Canada, and we weren't alone in that. A lot of countries experienced incredible challenges to get the study to happen, and it's really quite remarkable, all of the blood, sweat, and tears that has happened around the world to make this happen. And there were varying degrees of success. Some countries were only able to make one side of the study happen, either the outpatient side or the inpatient side. So for example, India was outpatient and Argentina was inpatient, and others attempted both but had relative success with one and struggled in another area, like Colombia, for example, and South Africa. So there was a lot of different experiences around the world, a lot of different struggles, but really it's a lesson in perseverance and really a success story. All right, so some of the challenges, of course, logistics around COVID, and we're going to talk mainly about the logistics around remote consent. But of course, we also had to consider things like screening, study drug provision, and doing follow-up remotely, which also had some of its own challenges. Now, we weren't alone in this effort to try and figure out how best to tackle these challenges. Lots of very smart people from our REB, from Health Canada, had lots of good insight to share. In fact, Health Canada has put out a guidance document. If you're not familiar with it, I definitely recommend checking it out. That gives a lot of guidance about how to run trials during this unique era that we're in. This is small text, but I just want to mention a couple of things they have. Some good guidance and about things to consider, like infection control measures and burden on resources. And they also have a whole section about guidance about informed consent. This is just to show you that it's there. That was in May of 2021 that was put out. And just to kind of touch on a couple of the key things that are included in that document, because I think if you are coming to this talk today because you think you may need to be doing remote consent in the future, it would be important to be clear on what the current guidance is on that. First, consult your REB. I definitely recommend doing that. They also say, of course, if you're doing video call or telephone call and doing verbal consent, make sure you're reading the consent and ensuring there's opportunity to discuss questions. Consider providing written consent in advance. So for example, you send the consent form by email and you can go over it together on the phone. Consider a text or emailed photo of a signature or data consent or a statement that attests to the patient's consent to participate. A witness attestation of a family member who is present to witness the verbal consent and can send a witness attestation. That's another approach. Or recording a verbal consent. And then, of course, that recording becomes the source document. And they also advise to consider local privacy rules. So those are all very important and helpful guidance in approaching this. Now, we started our study before that guidance was available. So what did we do? Well, we consulted our REB on what's the best method, thankfully, and that was very helpful. And what we had landed on at that time was that if a wet ink consent was not possible, we would accept a verbal consent by telephone, followed by a participant's own written consent or attestation sent back by email. Or we would accept a verbal consent by telephone, followed by a witness at the participant's side. So for example, their husband or wife are standing there with them and witness the verbal consent and conversation, and they would send back by email an attestation. Or we also accepted a verbal consent by telephone, followed by a witness at the site side attestation. So if you have a colleague who's sitting there and can sitting there with you and can witness the conversation. So that was perhaps one that was different than what the Health Canada guidance ended up landing on. And it's not one that we used quite a lot, but that was one of the options at the time. It is important to note that different jurisdictions and geographies had other specific requirements that they wanted implemented. So for example, in Quebec, they required a photo of the wet ink signature and data consent page. So it is very important to make note of what individual requirements are in different places. All right, so certainly that was the lesson, is that different sites, different geographies use different strategies. In determining what strategy was to be used, of course, the first question is the patient there or not there? Is the patient on a ward or in an outpatient clinic, or was the patient at home? In many cases, in parts of the world that did have really high success with enrollment in the outpatient setting, it was because they had an outpatient clinic. So in Egypt, for example, they enrolled a lot of outpatients. And it's because they have a process where patients with COVID-19 go to an outpatient clinic after their diagnosis to see a physician and to get treatment. So it was very easy to enroll there, for example. The next consideration is, where is the research coordinator, the person who's going to be conducting the event? If they're on the ward or in the clinic, it's very simple. They're in person with the patient. But it might be that they're not able to access the ward because of infection control or PPP measures. So that was another setting, another scenario that we faced. And of course, for the home setting, the research coordinator could have been at their office contacting a patient at home, or they might have been at their own home. And so there's different considerations in each of these scenarios that had to be worked out. This is the traditional model with a wet ink signature, but of course there were other considerations that had to be worked out, and Catherine's going to discuss a little bit about this. And if your research coordinator was in the office, that was a remote strategy, but also if they're at home, then there were additional things to consider, like security and confidentiality. So really, the scenario that was used most commonly around the world, and certainly was the most successful. This is our Ontario inpatient experience that Catherine's going to tell you a little bit about. And this is our Ontario outpatient experience. Another interesting thing that we implemented, and this was really based on tackling a resource issue that we experienced, and we wanted to pilot a strategy that used a hub and spoke model for outpatient enrollment. And what that was is we had sort of our PHRI core team, that's what I'm part of, is effectively the sponsor of the trial. And then we had a hub recruitment team in Hamilton. So they were separate from our core team, but also located at PHRI. And then we had 3 referring sites that were spokes effectively in this hub and spoke model, and they referred eligible patients to the central recruitment hub team. All right, I'm going to pass the torch now to Katherine to take it away from her perspective.
Thanks, Heather. So I'm just going to speak to the site perspective, and most specifically our site perspective. And we certainly very early on we decided as an institution we wanted to participate in some COVID trials, because as we were all aware at the very beginning, there really was no effective evidence-based treatment for COVID. So we have a long history with PHRI, and when their trial landed on our doorstep, so to speak, I think we were fairly early adopters. And but that didn't mitigate that. We still had a lot of hurdles and trying to seek solutions to them. So one of the first issues that popped up its head is privacy. But because again, in the early days of COVID, where we were doing a lot of PPE preservation and we really wanted to preserve staff as well, we were asked not to be present on the unit unless there was a requirement for us to be there, as in giving actual hands-on care, delivery of care. So, you know, how then do you connect and become part of that patient's circle of care? So one of the things that we were allowed to do was follow basically our patient census of COVID, where they were, and through that able to connect with their MRP, most responsible physician, and ask if they were interested in having their patient participate. Again, not something we usually do, but because we don't always know all the MRPs, so that was, again, yet another hurdle. So we got around the privacy issue of being able to be introduced and review the chart and that sort of thing. That was reasonable. On the logistics from an infection control point of view, again, very early on, as everyone is well aware, there was a lot of trying to preserve PPE, trying to keep a very light footprint on the units. We cohorted all of our COVID patients on the same units. So we at least were able to connect with one person on that unit who would take our call, usually the charge nurse. And so we were able to kind of negotiate that, but it does present and quite a hurdle, because we didn't know. There was a lot that was unknown. Did you get it from fomites on a surface? Did you get it? There was as many myths amongst healthcare providers as there was amongst the general population. So once we established that we weren't going to be present on the unit, the next hurdle was then how do we get introduced to these patients and invited to be part of their circle of care, which is, obviously a big thing when it comes to privacy legislation. So again, we would connect with their MRP, and we circulated all the information about the trial to the medical team that was on the unit, as well as the nursing team that was on the unit. Some of our medical people were embraced it. Some were disinterested at a physician level and said, "Yeah, I'm just not interested in participating," and which then made it impossible to have their patient participate. What we found, one of the solutions to that is we ended up finding champions amongst the physician group who were really keen to promote the research, and that helped us at least up our ability to connect with the COVID patients, especially those ones that were moderately ill on the unit and could actually, speak and do their own consenting. So once we were introduced, again, you're in that unique situation where you're not having that face-to-face. In the early days, we were doing this all by phone. And, I have found over the many years of doing research is I really like to be able to connect physically, be in the same room, to have that conversation, to gauge, how the person's receiving the information. Did their eyes go up when we talked about one issue, and do I go back and sort of prompt them to ask some questions about that, or whatever, but you didn't have that physical connection. They also couldn't see you. I was a stranger to them. They hadn't laid eyes on me. I could have been any arbitrary person floating through the hospital. So that was difficult to do that by phone. As we traveled through the COVID journey, we put in patient virtual visits. So we were able to tag onto that through our patient experience office. And then we were able to do FaceTime or virtual calls with the patients, which again helped us with that connection to the patient. They were able to actually put a face to the name. And then we were able to actually put shots of the consent up and say, do you have your phone with you? Would you like us to email it to you? Text it, forward it to you in a text, like how do you want us to communicate with you? So that helped a bit. Still more difficult than in normal circumstances. And then again, trying to develop that relationship with these most responsible physicians, and they rotated through the unit. Some of them we have worked on other research projects together, so they were familiar to us. Others we really had no connection with, and that made research a much harder, for lack of a better word, a much harder sell, because they didn't know us. They didn't know what our role was because they hadn't previously had any clinical trials experience. So again, once we developed a couple of MD champions on the units amongst the physician staff, that really helped. And we started circulating more information via email and Teams meetings and such. And amongst the nursing staff, they were much more receptive in the sense we were able to, through the educators, we did a lot of online educating, made slides available, made quick reference sheets available to them with numbers on them and who do you call. And we were able to supply that. We very early on, once we knew that we were going to do this, we engaged the pharmacy staff and our form staff to develop our electronic order set. So that made doing that piece of the trial much easier. So we did a lot of educating, we did a lot of support, and out of it all, we did a lot of learning, you know, things that worked really well, which were the virtual calls with the virtual visit volunteers, which were redeployed staff, and realize that in a situation like this, education and support of the staff was really key. Finding people who would really champion the study in your absence and remind the physicians that, hey, we've got this study, you know, we have nothing else. Can we give it a, like, what do you think? What are your thoughts? And so we had a modest success, but you know, probably not what we're used to in a trial like this. So we can go to the next slide. So again, just not to you know, beat the point, but again, initially our consent was by phone, which I'm sure many of you can attest to is less than ideal. And then we transitioned to the virtual visit program. So we were able to contact via FaceTime, which was again, somewhat better, but comparatively for most of our inpatient study, where we have about a 60 to 80% consent rate per 100 patients approached, but with ACT, we had less than 10%. So, you know, that inability to connect with them in person really impacted our ability to consent. And I think there was a lot of a lot of misinformation floating around that you had to, that because you couldn't be in person to create a dialogue with that patient, you were swatting away, no, we don't take hydrochloroquine like that you buy for your fish tank, and no, we don't take ivermectin that you buy in the feed store. And so again, there was a lot of, even in the early days, there was a lot of myths about treatments for COVID that we also had to slog through. So again, the biggest limitation was really not being able to connect on a very personal level with your participant, which I've always felt was key to success in research, both in the patient's willingness to stay the course with the research and for your ability to really, truly provide them with informed consent. So next slide. Do I have another one? Yeah. Now, our referrals from the spoke in our outpatient setting, we had a few hurdles. One was timing in the early days, and it sort of dogged us throughout, was we had a limited time from their PCR test to enrollment, the actual receipt of a positive test. So in the early days, we were getting these PCRs where the lag time was sometimes 5 days, which then gave us exactly less than 2 days to turn this around to the hub site and get that information transferred over. So at that time I was alone. So it was difficult, but we got it done. And verifying that consent to contact was documented. Again, our ER doctors, initially our assessment center was staffed by Southlake and created by Southlake. So our ER doctors were, again, very early adopters and very supportive. They actually, every person they did a PCR test on, they asked them if we had consent to contact them from the hub. And if they said yes, they documented that in their electronic medical records. So we had verification. I would go in and verify that in fact they had consented. But again, you know, time consuming because you're doing a lot of verification before you send it, et cetera, but at least we had it. Unfortunately, when public health took over, that changed, which meant we weren't registering them as a patient visit. So we weren't able to register that in an EMR, but it would in their EMR, but we were still able to register it on a spreadsheet, which we kept a master of with actual names and dates of birth. That was not sent to that was also sent to the hub. Again, when we had our own staff in there and we were registering them as patients, we were actually quite successful. I think in the latter days we were less successful because we didn't have that same connection. And again, I would, you know, and we started to also have some COVID fatigue ourselves. You know, the physicians were getting tired. and that's probably a different topic for another day. But I think we were more successful in our outpatient setting than our inpatient, because again, those people that showed up at the assessment center, at least were able to, there was some physical contact with the person who was talking to them about the study. So we were 100% more successful in our outpatient than our inpatient. We enrolled more outpatients than we enrolled inpatients. So back to Heather.
All right. Thanks, Catherine. Maybe just to give us a little bit of context and clarity, I want to talk a little bit about the workflow for the hub and spoke model and how it worked. Southlake was one of 3 sites that forwarded referrals to the hub center. As Catherine mentioned, the first step was the assessment center. The initial approach was from the physician who was doing the COVID test, and at the time asking if they have a positive outcome or a positive result, if they would be willing to be approached for research. And then the next step was the local site RC. So for example, Catherine at Southlake or the local RC at the other 2 sites would pre-screen that list, look for age criteria and other dates out of window. As she mentioned, the timing was a challenge. And there were a couple of other considerations in some cases. At one site, for example, the physician did some follow-up calls for positive cases to support the public health backlog at the time. So the physician that did their test, or one of the physicians from the same assessment center, was calling the positive cases, and it was a second point of contact from that same assessment center, which is a very powerful thing. At a different site, they had a very slightly different approach, where the site RC called those patients before forwarding them on to the hub recruitment center, and did one other screening aspect, which is symptomatic. So she's getting the whole list of COVID positive patients that agreed to be approached, and she's screening out the ones that are asymptomatic because they won't meet criteria, so there's no point in passing them on. And then there was a third site that didn't have a second contact. They just had this initial approach and the weeding out of the age criteria and the dates. Next step was the hub recruitment center would receive those lists, and they would contact those patients that were on the list. It wasn't a cold call because, of course, these patients had at least 1, if not 2, previous approaches asking about their interest in research if they're positive. And so it was not, it was not an unexpected call at that point. The hub team would assess their full eligibility criteria and conduct the informed consent. And what was the result? From these 3 sites, we had 898 total patients referred that were attempted to be contacted by the hub recruitment site. 50 of those participants were enrolled. So that gave us a 6% conversion rate. And as Catherine said, it's almost heartbreaking to see those numbers, right? Because we're used to 70 to 80% conversion in a typical in-person trial. So it's hard to see those numbers because you recognize how much work went into getting them. In terms of the differences in these 3 approaches, did that impact success rate? Oh yeah, a little bit it did. So for example, at this site where the physician was doing a second call, it meant there was a fairly large number of patients to be referred on, and 5.6% of them were enrolled. So that's fairly good. At the other site where the site RC was doing the pre-screening call, fewer patients could be referred and passed along because, of course, the list has been pre-screened and weeded out the asymptomatic patients. And of the ones that are left, 11.9% was enrolled. So it may seem, oh, well, this is better, but really it's sort of 6 of one and half a dozen of the other. Of the referral rate, it's a higher return of investment from the hub's perspective, but of course there's a resource cost here for this research coordinator who's doing that pre-screening call. The one important lesson was for the third site, they didn't have a second contact, and of 198 potential participants referred, none of them were enrolled. So that, I think, is a clear message that having that extra contact, that direct contact, is important. There was a 4th workflow that happened at Hamilton Health Sciences. We had a special consideration in Hamilton, special approval through our privacy officer and with a waiver of consent through our RV, where the positive cases could be forwarded directly from the Hamilton lab. In this case, of course, it's a much larger list of potential participants. Again, similar process happens from the site Hamilton RC, who's filtering out for age criteria and contact information available, which of course the data that's coming in at this point now from the lab is going to be much spottier and have you know, a lot more missing data and that sort of thing. And then the Hub Recruitment Center would call these list of participants. Now, in this case, it was different. It was a cold call. So there was no previous approach. So much more difficult. Again, though, the Hub team would go over their eligibility criteria in full and review the consent if the participant or if the potential participant was willing. What's the result? Oh boy, over 29,000 participants were attempted to be contacted. So that's a huge number of man hours. And of those, 210 were enrolled. 210 is great. That's a lot of participants enrolled, but the man hours required to get there was extreme. The conversion rate in this case was less than 1%. Now, I will say this was possible because the Hub team was supported by a small army of volunteers who were, and the Hub team themselves were involved in investment and training for those volunteers. A lot of medical students participated as well. We got them all trained in their GCP and able to be involved. And that was why this was possible. But it was still quite a large investment of time. The Hub team shared some really important lessons about what were the biggest hurdles. Of course, cold calling, if this is no surprise. Trust and credibility is so important. One of the Hub team coordinators was telling me a story about one of the patients she spoke with who said to her, "You're telling me you're calling from Hamilton Health Science, but I really don't know. How do I know you're not just someone who's trying to steal my identity and you know you're a scammer? We really don't know." And that's the challenge of just doing a call from the telephone. So even if it's possible logistically to do this, you have to make sure you assess whether it's worthwhile to do it. Another challenge, sign of the times, is difficulty just getting people to answer the phone. And I have to admit, I'm sort of guilty of this myself. If I see a number I don't recognize, I'm very unlikely to answer it. I'm more likely to see if if it's something important, I'll leave a message or something. So that was definitely a challenge as well. One of the important things they tried to do to accommodate this problem is to use a special sort of VoIPer app that would allow them to make sure that the ACT study Hamilton Health Sciences on the display for the name, but it was inconsistent in how it functioned. So that was a challenge as well. Timing constraints, as Katherine mentioned, was also a big challenge for that Hub team. When they get that list, of course, time passes as you're trying to contact these patients. So